Now it's my great pleasure to introduce Professor Kelley, who is, as you can see, far away from us. It's quite early for you. Thank you very much for joining us, Katie. So it's a few years we are discussing to have you on this program. So finally it's happened. Thank you very much. And you would like to talk on biliary tract cancer, which is also quite important. And again, the foundation is against liver cancer. So there is also biliary tract cancer. And you will talk about combining chemotherapy and immunology, first line for biliary tract cancer. Thank you very much, Katie, to be here.
Thank you so much for the invitation. It's quite an honor to be here. Can you hear me okay? I'll take that as a yes. My name is Katie Kelley, and good morning from California, actually. Today, I have the privilege of speaking on a relatively new advance in biliary tract cancer, which is the combination of chemotherapy and immunotherapy in the first-line context. Here are my disclosures, largely related to conduct of multiple clinical trials. So here's the outline I'd like to review today. First, go over the background of chemotherapy and biliary tract cancers and the biologic rationale for combining with immunotherapy, and then go through outcomes for chemotherapy and immunotherapy in combination, beginning with early phase data, and then going into two pivotal phase 3 trials, TOPAZ-1 and KEYNOTE-966, and delving further into their subgroup and correlative analyses, as at least what exists so far, and then hopefully look to the future for what might be next. So beginning with background in biology, first I'll start with a bit of an alphabet soup of acronyms because, as you all know, biliary tract cancers are highly complex tumor types with multiple subgroups. So overall, these are uncommon tumors with rising incidence worldwide, around 2 per 100,000 overall, but much higher in certain parts of the world, including Japan, which may be as high as 8 or 9 per 100,000 people. The anatomy of biliary tract cancers is quite heterogeneous, and this is where we get to the alphabet soup part. We have gallbladder cancers, or GBC, in the gallbladder portion of the biliary tree. Then we have intrahepatic cholangiocarcinomas arising from the small intrahepatic epithelial bile ducts within the liver, or ICC. Tumors right at the junction of the hepatic duct to the common bile duct up until the cystic duct are referred to as perihilar or hilar bile ducts, or the old eponym Klatskin tumors. And distal to the takeoff of the cystic duct down to the head of the pancreas, we have distal bile duct or distal bile duct cancers, and together perihilar and distal account for extrahepatic cholangiocarcinoma, or ECC, which is what the subgroup commonly used in clinical trials is called. Beyond this enormous anatomic heterogeneity, biliary tract cancers also have very heterogeneous etiology and biology. So they're caused by a variety of very different types of underlying liver injury in a large proportion of patients. These can include some of the same risk factors as HCC, including hepatitis B and C virus or alcohol. Uniquely to biliary tract cancers, fluke infections in the biliary tree in certain parts of the world, particularly Thailand and Southeast Asia countries, can also cause chronic inflammation and leading to DNA damage and malignant transformation over time. The scourge on the horizon in really most parts of the world is now fatty liver, causing underlying injury and accumulation of mutations in the hepatic parenchyma and in the biliary tree. And so in addition to HCC, fatty liver is perhaps we think one of the causes of this rising incidence of intrahepatic cholangiocarcinoma, or ICC in particular. Despite all of that, most cases are still idiopathic. We don't know why most patients get biliary tract cancers. And so owing to the heterogeneous and complex anatomy and etiology, turns out that the genetics and microenvironment of these tumors are also highly heterogeneous, and in some cases linked to their etiology or anatomy, and others not so clearly so. So in terms of our chemotherapy for biliary tract cancers, these have historically been rare cancers without much level 1 evidence. Really, the first level 1 evidence arose from a trial called ABC02, which combined gemcitabine and cisplatin and compared to gemcitabine alone in the first-line setting for advanced biliary tract cancers. This study showed a survival improvement with survival of 11.7 for the combination, in a median overall survival, I should say, versus 8.1 for gemcitabine alone, with the Kaplan-Meier curves shown here. The response rates were 26% with combination versus 15% for gemcitabine alone. And I include that just as a benchmark for what we should expect for GemCis. And if we look at the forest plot, we can see that most clinical subgroups of biliary tract cancers showed benefit. And so the addition of cisplatin improved overall survival across most clinically relevant subgroups. So gemcitabine plus cisplatin became the standard regimen per the ABC02 trial around 2010. So after that, there have been few other first-line trials with any positive results until recent years. The first next positive trial after ABC02 was the Mitsuba trial combining gemcitabine, cisplatin, and a third cytotoxic agent, the fluoropyrimidine S1. This was conducted exclusively in Japan, and which is why we don't see as much of, we don't have this agent approved in the United States or Europe, and it's not a widely used regimen outside of Japan. But this study did show an improvement in the median survival, which was the primary endpoint, 13.5 versus 12.6 months, though not strongly positive, but it was a positive study. PFS and response rate were also higher with the triplet, but so were grade 3 events, including diarrhea, stomatitis, and rash. Another important and recent study looking at a triplet of chemotherapy, taking gemcitabine, cisplatin, and adding the taxane nab-paclitaxel, was the US intergroup study SWOG 1815. And this study randomized patients to standard gemcitabine plus cisplatin versus the triplet of gemcitabine, cisplatin, and paclitaxel based on phase 2 data with a 2-to-1 randomization. And unfortunately, this study did not show a significant improvement in overall survival. It was a negative study for the primary endpoint. There was a trend towards higher objective response rate, but it was not significant. And again, there was actually a pretty meaningful increase in grade 3 adverse events, particularly those related to myelosuppression with the triplet agent. So this regimen is not moving forward as an approved regimen in the first line setting, owing to no significant improvement in efficacy and higher rates of toxicity. So to summarize what we have with first-line chemotherapy data alone in biliary tract cancer, the gemcitabine plus cisplatin combination achieves a median overall survival around 12 months and a response rate in the 15 to 25% range in contemporary studies with a 2-drug chemotherapy regimen. Adding the third agent, such as S1 or nab-paclitaxel, can improve objective response rates, but has a modest impact on overall survival and higher rates of toxicity. And the median duration of response is limited, meaning when people respond, it tends to be up till 6 to 7 months of benefit, and after that, patients progress. So it is not a long-term solution. So I mentioned earlier that the microenvironment of cholangiocarcinomas is quite heterogeneous, in part due to the varying etiologies and anatomy. And here's an interesting study which looks at a subset of intrahepatic cholangiocarcinomas predominantly, and shows that only about 10% of them are immunogenic or have a hot microenvironment. The majority of these are cold tumors and either immune excluded or myeloid or fibrotic in their microenvironment. We also know there are very low rates of markers associated with immune responsiveness. So there are very low rates of TMB high. The study shows a median TMB of around 2.2 in biliary tract cancers. And only about 2 to 3% of these biliary tract cancers have microsatellite instability or mismatch repair deficiency. So overall, this is a cold tumor type. And as expected for a cold tumor type, immune checkpoint inhibitors as monotherapy have shown very limited efficacy. The best example of this is the Keynote 158 trial that had a little bit over 100 patients who were majority of almost 99 to 100% of them were mismatch repair proficient. There were a couple unknown cases, but overall about 99% were mismatch repair proficient, not MSI high. And the objective response rate was less than 6% overall, without a huge difference according to PD-L1 status. And the median progression-free survival was only 2 months. We see similar results with response rates less than 10% for most other immune checkpoint inhibitor studies, once reviewed centrally at least. That includes nivolumab and durvalumab. But across all of these studies, the encouraging result is that the immune checkpoint inhibitors have been well tolerated with very similar rates of immune-related adverse events compared to other tumor types and no excess of hepatic toxicity or any warning signals. So based on this safety, but lack of striking efficacy, the question arises, would combining chemotherapy with an immune checkpoint inhibitor improve the chances of eliciting an immune response? So there are reasons to think that combining an immune checkpoint inhibitor with chemotherapy could augment the immune response. And this is a sort of a broad category of approach that has been taken in a lot of different tumor types now. And on high, there are a variety of different ways that chemotherapy can promote immune responses. So cytotoxic agents can elicit pro-inflammatory cytokines and change the microenvironment towards an immune response. They can trigger immune cell infiltration, and particularly the cisplatin in our gem-cis regimen can cause ferroptosis, a type of cell death that really encourages effector cell infiltration. Chemotherapy can inhibit regulatory T cells and myeloid-derived cells that could be pro-immune response. And again, it's specific to gemcitabine. Chemotherapy can increase tumor immunogenicity, and the immune antigen presentation, such as gemcitabine's increase in MHC1 expression and antigen presentation. So these are all theoretical ways, and with some preclinical data, that chemo can help immune checkpoint inhibitors achieve an immune response. So looking at early data of immune checkpoint inhibitors with the gem-cis regimen, there are a host of small, single-arm studies that give a little bit of a signal, and I won't go through all of those. This is just one such example that highlights, an encouraging signal. So combining nivolumab plus gem and cis in this small 30-patient study showed a response rate of around 36%, which is, again, much higher than we expect with gem-cis alone, but not out of the range of possibility when you're only dealing with 30 patients. But we see that some of them are quite durable, again, limited follow-up for single study, small data set. So again, a little bit of a signal, but nothing to make a sweeping decision based on because of the small size of the study. Now, a larger study was done that's worth noting, which was taking gemcitabine, cisplatin, and durvalumab plus minus the CTLA-4 inhibitor tremelimumab in Korean sites led by Do-Young Oh et al. And this was a much larger study with 120 patients, a very complicated design in which patients were allocated to 3 different arms, either the triplet with a whole bunch of biomarker collection, or the 4-drug combination, because there's 2 immunotherapies in this one. So the 4-drug combination with a lot of biomarker analyses, or the gem-cis plus durvalumab 3-drug cohort, or the gem-cis, durvalumab, and tremelimumab, a different 4-drug cohort. And so looking at the biomarker data from the first cohort in particular, those are the 3 cohorts I just mentioned. Looking to the initial data from the study, we see that first, there's most patients had radiographic regression, and actually they had quite remarkable response rates in this study, up to 72% for the combinations, with the caveat this is locally assessed in a selected population of Korean patients. I think, again, the caveat with the study is that the response rate is much higher than we'd expect for gem-cis alone, and higher than what we'd seen with the other combinations, such as the nivolumab study, which showed a 36% response rate. So again, these data must be taken with a grain of salt, but certainly provided a very strong, interesting signal. And then looking to the biomarker analyses from the first cohort in particular, I think some interesting things to draw from here, that one, PD-L1 expression in TMB, which again have not been very prevalent, or TMB is usually low in cholangiocarcinoma, but in this study, they were not predictive of response. A couple mutations were perhaps poorly prognostic, ARID1A and CDKN2A, which we know from other data sets as well, had worse outcomes. And then this is, I think, the part that's most intriguing in terms of mechanism. Once patients started treatment, those patients whose tumors had a higher PD-L1 expression after exposure to chemotherapy did have better outcomes, and including survival, PFS, and response rate. Patients whose tumors on chemotherapy had a decrease in PD-L1 had worse outcomes. And so I think this is interesting because it speaks a little bit to mechanism that tumors that in the face of chemotherapy had an inflammatory response or increased their PD-L1 seem to do better, and supports, admittedly, mildly supports the hypothesis that we're eliciting an immune response by adding the chemo. So that's the relevant early phase trial data in my mind. And now I'll turn to the pivotal phase 3 trials, TOPAZ 1 and Keynote 966, and their subgroups. So beginning with TOPAZ, TOPAZ 1 was a double-blind, multi-center global phase 3 trial. It enrolled patients with locally advanced or metastatic biliary tract cancer, so intrahepatic, extrahepatic, and gallbladder. And all patients had previously untreated or metastatic disease at diagnosis or recurrence after greater than 6 months from prior surgery or adjuvant therapy. Patients were randomized 1-to-1 with a total sample size of 685 patients to either durvalumab plus the Gemcis chemo backbone or placebo plus the Gemcis chemo backbone. And an important design point was that based on the original ABC02 trial, this trial elected to require that after 8 cycles maximum or 6 months, all patients switched to either maintenance durvalumab alone without any more chemo or placebo without any more chemo. And this is a little different than Keynote 966 and a little different than practice pattern in some part of the world, which may continue gemcitabine long. And after 6 months, patients were randomized or either remain on durvalumab maintenance or placebo maintenance, no chemotherapy. The primary objective was overall survival, and secondary objectives were progression-free survival, objective response rate, duration of response, which I think is a very important endpoint in immunotherapy studies, and then PD-L1 status and safety. So the primary endpoint, overall survival, showed improvement with the addition of durvalumab with median of 12.8 months compared to 11.5 months and a significant hazard ratio of 0.80. And as we look at the curves, we can see that the purple curve with durvalumab really is showing an increased separation of the curve with time, suggesting perhaps that these patients at the tail of the curve are truly having a deep and durable immune response. Progression-free survival was also prolonged, and objective response rate was higher with the purple group, the addition of durvalumab. And again, speaking to immunotherapy and the potential for deep and durable immune responses, we see that patients with objective responses had the longer duration of response. The DOR in small print here is the duration of response, and the purple curve on durvalumab have a much longer duration of response, which is what we hope for with immunotherapy. The safety was quite similar in both arms. The serious adverse event rates, grade 3-4 rates, discontinuation rates were nearly identical without any significant signals. The immune-related adverse events were also as expected for durvalumab as monotherapy, around 12.7% in the combo arm versus 4.7% in the placebo arm. And grade 3 immune-related adverse, grade 3 or higher were quite low, only 2.4%. So again, very reassuring safety that this is not harming patients. And if we look at subgroup analyses, we can see again that almost all of these key clinical subgroups actually all of them fall to the left of the line of equipoise. So all relevant subgroups seem to be showing at least some benefit with similar magnitude. And there have been subsequently to TOPAZ presentation, there have been additional subgroups according to part of region of the world. We saw, again, pretty similar outcomes according to Asia versus Western sites. And that holds true for extrahepatic, gallbladder, and intrahepatic as well by an anatomic subsite. And I think I circled this box here, race, Asian versus non-Asian also, again, showed similar trends. Though, again, there was a slightly more significant benefit in the Asian subgroup than non-Asian in this study, though that's different in Keynote, which I'll show you next. So based on the consistency and strength of the data and the safety, the US FDA approved durvalumab in September of 2022. And since then, many other regions of the world have approved the addition of durvalumab to gemcitabine plus cisplatin. So here's a typical case, a patient from my clinic, just to share a TOPAZ 1 treatment example. So this was a 67-year-old who had a extrahepatic distal cholangiocarcinoma, and had a KRAS mutation, an ATM mutation that was not germline, it was tumor, and got surgery, and then adjuvant capecitabine with a low CA19-9. Unfortunately, about a year later, he had recurrence with the high CA19-9 and peritoneal carcinomatosis on his PET scan. Here's a couple little spots. He had some lymph node positivity as well, and a biopsy of one of these peripancreatic lymph nodes confirmed that it was recurrent adenocarcinoma in the peritoneum. So we put him on gemcis plus durvalumab per TOPAZ-1. And he did quite well, had some mild rash at the beginning, and then had a complete response. So no visible tumors, a normalization of CA19-9, and did quite well. After 6 months, we switched him to maintenance durvalumab. And about 7 months later, unfortunately, he progressed. So again, he did not have as durable of an immune response as I had hoped, but the converse is that he had around a 7-month chemo-free interval without any sign of progression. And then when we progressed, we put him on a second-line clinical trial, at which time he progressed immediately. And then now he's on third-line FOLFOX, unfortunately having a bit of a chemo response again. But I do think the durvalumab was a contributor to this chemo-free interval for him. So turning to the next phase 3 trial, this is a study I had the honor of being a part of, the KEYNOTE-966 study, which was a very similar study to TOPAZ-1, but with the PD-1 inhibitor pembrolizumab as the immune checkpoint inhibitor instead of durvalumab. So here's the schema for KEYNOTE-966. Again, similar eligibility criteria for advanced or local or unresectable primary biliary tract cancer, no prior systemic therapy, and adequate ECOG. Patients were randomized 1-to-1 to either pembrolizumab plus gemcis or plus placebo plus gemcis. And the key difference here in the design compared to TOPAZ-1 is that after 6 months or 8 cycles of therapy, the investigator and patient had the option to continue gemcitabine, which most patients did. That was either gemcitabine plus pembro in the treatment arm or gemcitabine plus placebo in the control arm. So unlike TOPAZ, after 6 months, the control arm continued gem, as did the treatment arm in most patients, and so that does impact the outcomes to some degree. Primary endpoint was overall survival. So here's the overall survival at the final analysis with 1,069 patients enrolled. So this is the largest phase 3 trial in the history of biliary tract cancers to date. And we see a sort of a sustained separation of the curves, with the green curve inclusive of pembrolizumab showing prolonged survival at the 12 and 24-month landmarks, a little bit of a separation in the curve around 24 months, and then it's harder to tell here because of small numbers and incomplete follow-up that beyond the 24-month mark. But again, a significant hazard ratio of 0.83, and ultimately this was a significant study and a positive study for improved overall survival. Now, here are the pre-specified subgroups at the final analysis, and we again see for most of this pre-specified clinical subgroups, there's benefit for the pembrolizumab addition. This includes Asia versus non-Asia, with a slightly more strong trend towards benefit in the non-Asian group in this study, unlike TOPAZ. So again, these reinforce that both Asia and non-Asian patients and regions benefit. We see no significant difference by PDL1 score. That was true for TOPAZ as well. I didn't highlight that earlier. And we see the intrahepatic group fared the best in this group study. There was less benefit or less clear-cut difference for extrahepatic or gallbladder, but I'll cite the caveat that these patients have more comorbidities and are much more difficult to show benefit in due to complications of obstruction. There wasn't a significant difference in objective response rate in KEYNOTE-966. Both groups had about a not quite 30% rate of shrinkage. That said, like TOPAZ-1, the median duration of response was significantly longer and showed greater benefit over time in KEYNOTE-966 with pembrolizumab arm, reinforcing also that these are durable immune responses. So again, I'll highlight the 24-month rate that responders had around a 20%, 18% chance of remaining in response for the pembro arm compared to only 6% for the chemo arm. So not nearly as high as we'd like, but again, a difference there. Safety was also quite reassuring. Really no difference in key high-level safety parameters for pembrogem-cis versus placebo-gem-cis, and the steroid utilization rate for adverse events was less than 10% in the treatment arm. So based on this data and this large phase 3 trial, the FDA approved pembrolizumab to be added to chemotherapy with gem-cis for biliary tract cancers in October of 2023, and is now an alternate first-line option. So I'll go through a couple more subgroup and correlative analyses, particularly from TOPAZ-1, since these have not yet been published from Keynote. So from TOPAZ-1, a biomarker data set entailed 685 patients, and around 300 each for placebo versus the durvalumab groups that were analyzed for PD-L1 status and mutation profiling. And we see the distribution of baseline mutations is what we'd expect for an advanced biliary tract cancer patient. In green are the ones that are potentially clinically actionable, like IDH1 and HER2. And down here, we see the rate of FGFR2 aberrations was quite low in this group, around 3.4%. So that was the baseline. And then if we look at outcomes according to mutation, we see that overall, most key mutation groups had pretty similar benefit according to wild type versus alteration with the addition of durvalumab. A couple outliers to highlight that were not so clear-cut include CDKN2A loss, ARID1A, again, these are poor prognostic factors, but also ERB2 amplification, where we see a little bit of difference with the caveats that the numbers are so small, they're hard to interpret. And we don't have enough patients to analyze for some of these other groups like BRCA, FGFR2, and BRAF, but overall, similar benefit. Same with response rate, with just one exception where IDH1 showed a trend towards perhaps a higher response rate in the placebo arm than the treatment arm. Really too small of numbers to draw any conclusions, but I think the key point is that these analyses are really important, and we need more data to be able to refine which patients might benefit the most. Right now, the signal seems that most patients treated with durva, the purple bars seem higher. Again, the only exception where the yellow bar is higher for the placebo arm is really IDH1, but again, 9 patients versus 18 patients, super small numbers. So to conclude, the addition of either anti-PD-1 with pembrolizumab or anti-PD-L1 with durvalumab improves survival in first-line advanced BTC when combined with gemcitabine plus cisplatin. The median overall survival improvements are modest, but at the tail of the curve, there are a greater proportion of patients with prolonged response and survival in the immunotherapy arms in both studies. And this benefit appears independent of whether gem is continued as maintenance or not. The improvement seems pretty consistent across geographic and molecular subgroups, a couple of outliers that I mentioned with the huge caveats that the numbers are too small to draw any firm conclusions. The anatomic subgroup suggests probably the greatest benefit in intrahepatic, particularly for Keynote, and less differential benefit for gallbladder, but this is highly contaminated by competing comorbidity of the gallbladder and also in some cases extrahepatic subgroups. The combination is quite safe, and collectively these data have led to regulatory approvals in the US for both combinations and already for durvalumab in several other parts of the world, including EU and Japan. Key questions and future directions. We, of course, want to learn which patients benefit the most, how to select our patients. We need to look at individual mutations with larger sample sizes, and I think this is where we need to advocate as a field for Merck and AstraZeneca to try to let us do combined pooled molecular subgroup analyses. I know that will be difficult. The fundamental question for combinations like this is, are we seeing synergy or sum of parts? Are we just capturing a few immune checkpoint inhibitor responders additively on top of chemo? We can't tell, I think, for sure yet, but there is the biomarker data from the phase 2 trial and the prolonged durations of response, which I hope speak to the possibility of some synergy in at least some patients. And then in terms of, is this a new standard of care? I would say yes, but not enough patients are getting the prolonged benefit that I'd want. We need to keep working to make more progress with either better combinations, identifying subgroups that benefit the most, and learning how to use these strategies in earlier stages of disease when patients may be healthier and able to benefit more or mount a better immune response. So with that, I will thank you for your attention.
Thank you very much. Thank you very much, Kathy, for all this presentation about these different trials. And we see that biliary tract cancer is also getting quite crowded now with possibilities. Do we have any questions? Otherwise, I would like to... okay, let me just open that. A second, if I can see them. Yes, effectively. Okay, so I will read them to you. How do you envision the integration of chemotherapy and immunotherapy in the first-line treatment of biliary tract cancer impacting overall survival and progression-free survival compared to current standard of care approaches?
I think the two trials, Topaz-1 and Keynote, do show a small but significant improvement in overall survival. And for Topaz, PFS as well. So I think there is a small improvement, and again, a subset of patients get long benefit. And I like the case I showed, there was a nice greater than 6-month chemo-free interval that was very valuable to that patient.
There is a second question. Given the heterogeneous nature of biliary tract cancers, including cholangiocarcinoma and gallbladder cancer, how do you anticipate patient selection criteria for combined chemotherapy and immunotherapy regimens evolving to optimize efficacy while minimizing potential adverse effects? So
I'd say that one clear-cut conclusion from both studies is there were very minimal difference in safety by adding the checkpoint inhibitor. Only a very small percentage of patients had immune-related toxicity. So the safety was not a concern with either study. We are using this as our standard first-line triplet combination. So we give all patients an immune checkpoint inhibitor unless they have a contraindication such as prior liver transplant or autoimmune hepatitis or other underlying autoimmune disease.
And we have a third one. Could you elaborate on any ongoing or upcoming clinical trials investigating novel combinations of chemotherapy and immunotherapy agents specifically tailored for biliary tract cancer? What key endpoints are being assessed in these trials, and what preliminary results are emerged thus far?
So a couple of different strategies to speak immediately to. There of course is the impulse to add more drugs, add another immune modifying agent, which again, then we really have a hard time sorting out what is the component contribution of when we add a different agent. But the IMbrave 151 trial was presented at GI ASCO in 2024, 1 month ago, looking at gem, cis, and atezo-bev, so adding bevacizumab to the triplet of immune checkpoint inhibitor plus gem-cis. And it showed an improvement in progression-free survival, but not a significant improvement in survival, and is not moving forward owing to the sort of lack of clear-cut strong efficacy and the challenges of having a 4-drug regimen, but there was a signal towards improvement. And specifically in the hepatocyte-like subgroup, so patients that had tumors that looked more like HCC, by their transcriptome analysis, showed greater benefit. So that was what was presented at GI ASCO, the subgroup analyses. So that's one approach to add more, but that gets very expensive and also very difficult to prove that you're actually achieving benefit without really large studies. Another strategy is to look at this question in subgroups by molecular status and try to harness immunotherapy and a targeted therapy. And one example of the trial on Horizon is looking at HER2 targeting agents with chemotherapy plus minus immunotherapy. And so I think that's a next wave of trials that we may see is targeting HER2 in some way with or without immunotherapy.
And I have a question also. We had some headache in Switzerland with these differences in the Topaz-1 Asia vs non-Asia with the regulatory authorities. So how do you interpret that this less efficacy in this trial in the non-Asian patients?
So that was in Topaz. I think that's a question with a lot of different hypotheses, including whether there's a difference in immunogenicity for underlying hepatitis B exposure or not. That's we, I think, are falling away from that belief in HCC in particular, that it's more complicated than just viral status. There's a lot of different practice patterns. There's also differences in access to downstream therapy. So I personally think that those subgroups are very difficult to interpret for overall survival. If you look at TOPAZ and look by response rate, that there is no difference by etiology or location. And I think that's what I would respond to the authorities with, which is that after progression, a lot is different according to region and underlying liver disease. But until progression, that gives you a cleaner readout of true efficacy. Obviously, overall survival is our best overall endpoint, but when looking at subgroups, it's very hard to interpret trends without factoring in post-progression unrelated issues like access to downstream therapy or comorbidity. So the response rate, I think, helps you interpret those forest plots. And Keynote 966 showed
Right.
alternately greater benefit in
Right.
the
Right.
non-Asian
Yeah,
group.
that's very
So
helpful.
putting those together, I think there's no clear-cut difference.
Well, thank you so much for being with us today. Yeah, I know you're very busy leading in many trials, especially this last one. Congratulations for sharing the data with us, and to also get up early. Thank you very much. We much appreciate it, and we wish you a good day. And